We need to talk about the system that was built to protect those who protected us, and why, after years of trying, so many veterans are finally walking away. If you or someone you love relies on VA healthcare, you know the promise: comprehensive, lifetime care tailored specifically to the unique burdens of service. But the reality? For a growing number, that promise has dissolved into a nightmare of endless waiting, bureaucratic fighting, and a level of care that is, frankly, unacceptable. We're pulling back the curtain on the 7 core failures that are pushing veterans to quit the VA system entirely, even when they have nowhere else to go. Stay tuned, because the final point, the hidden financial shock, is the one that blindsides almost everyone. The first issue, the foundational failure that sets the stage for everything else, is the illusion of comprehensive care. When a veteran enrolls, they are sold on the idea of a complete medical home. They believe they are stepping into a system capable of handling everything from a common cold to complex, rare service-connected conditions. But the reality is a brutal patchwork of profound specialization gaps, especially when dealing with complex or rare conditions that require cutting-edge research or highly specialized regional expertise. You walk in expecting the best, but you quickly find that the local VA facility, even a major medical center, simply doesn't have the necessary specialists on staff. They might have a primary care doctor, maybe a general surgeon, and certainly mental health support, but try finding a neuro-oncologist specializing in blast-related injuries, or a rheumatologist who understands the specific autoimmune markers common in veterans exposed to certain environmental hazards. That level of niche expertise? It's often missing entirely. This isn't just about inconvenience, it's about life and death delays. If a veteran needs a rare procedure or a consultation with a top expert in a specific field, say a specific type of orthopedic reconstruction that only 3 surgeons in the country perform, the VA system usually cannot provide it internally. This triggers the dreaded referral process, which is supposed to be seamless, but is anything but. The waiting list for a routine specialist appointment can already stretch weeks, sometimes months. For a highly specialized internal VA referral, that wait multiplies. We've seen cases where veterans with aggressive cancers lost critical treatment windows waiting for the VA to confirm that, yes, they did not, in fact, have a doctor capable of treating them on staff. The system is designed to keep care internal, often prioritizing bureaucratic efficiency over clinical necessity. This internal bias means that veterans often receive generalized care when they desperately require specialized intervention. They receive the care the VA can provide, not the care they need. And let's delve deeper into the nature of these gaps. It's not just the rarity of the specialty. It's the sheer volume of veterans needing standard specialties that overwhelms the system. Think about cardiology, orthopedics, or dermatology. These are high-demand fields. The VA attempts to staff these positions, but often struggles to compete with private sector salaries and resources. This leads to a revolving door of providers who are either overworked, inexperienced, or simply not the best in their field. A veteran who has endured years of physical strain and injury needs consistent, expert orthopedic care. Instead, they might see 3 different orthopedic PAs in 6 months, each starting the treatment plan from scratch because the previous provider left. This inconsistency is the antithesis of high-quality health care. It erodes trust, delays recovery, and forces veterans to become their own medical case managers, constantly explaining their history, their injuries, and their needs to a new face every few weeks. This fragmented approach ensures that the comprehensive promise remains an illusion, a beautiful but empty brochure that crumbles the moment a veteran faces a genuinely complex medical challenge. The moment a veteran realizes the local VA is a bottleneck, not a resource, is often the moment they start looking for the exit. They understand that their health cannot wait for the system to catch up to the standard of care available just across the street. This leads us directly to the second massive systemic breakdown: the bureaucratic quagmire of community care. Community care, primarily governed by the Mission Act, was supposed to be the safety valve. If the VA couldn't provide timely or specialized care, they would pay for the veteran to see a private doctor. Simple, right? Absolutely not. This process has become a legendary maze, a labyrinth of paperwork, approvals, and denials that seems almost deliberately designed to fail. It is the single biggest point of frustration for veterans attempting to access necessary care outside the system. The moment a VA provider decides a veteran needs outside care, the clock starts ticking on an administrative marathon that often leaves the veteran exhausted and untreated. The referral process begins with a VA provider submitting a request. This request then enters a black box of authorization. It has to be approved by various levels of administration, reviewed against complex eligibility criteria, wait times, distance, specialty availability, and then, finally, sent to a third-party administrator, TPA. The TPA is responsible for finding a community provider willing to accept the VA rate and schedule the appointment. Here's where the system collapses into chaos. The communication between the VA, the TPA, and the community provider is notoriously poor, often non-existent. Veterans frequently find themselves caught in the middle. They call the VA says it's with the TPA. They call the TPA says we never received the authorization, or we can't find a provider in your network. Weeks, sometimes months, pass in this state of administrative limbo. We have documented cases where veterans were denied community care because the VA claimed a provider was available internally, only for the veteran to discover that the internal provider had a 6-month waiting list. The system checks the box for availability without considering the crucial factor of timeliness. Furthermore, the eligibility criteria are constantly shifting and often interpreted differently by various VA facilities. One veteran might easily get authorization for physical therapy outside the VA, while another veteran, living 50 miles away but under a different VA region, is strictly denied, forced to wait months for an internal opening. This inconsistency breeds immense resentment and distrust. Veterans feel like they are playing a rigged game where the rules change based on who answers the phone that day. The administrative burden placed on the veteran is staggering. They are required to constantly follow up, track down paperwork, and mediate between 3 different entities that refuse to communicate effectively. This is not how healthcare should work. Veterans, many of whom are dealing with chronic pain, PTSD, or serious illness, should be focusing on their health, not fighting a bureaucratic war just to get an appointment. The sheer mental exhaustion of this fight is a major contributing factor to veterans quitting the system. They realize that the stress of navigating the community care process is often worse than the ailment itself. They look at their private sector peers who can call a specialist and be seen within days, and they recognize the profound disadvantage they face. The promise of the Mission Act was speed and access. The reality is delay and denial. When veterans understand that the VA's own internal mechanisms are designed to frustrate outside access, they decide to bypass the VA entirely, seeking care they can actually control, even if it means paying out of pocket or relying on a spouse's insurance. The system's inefficiency has become a form of medical gatekeeping, and veterans are refusing to stand at the gate any longer. This bureaucratic paralysis is a deep, festering wound in the VA's reputation. Moving on, the third critical failure point that drives veterans away revolves around medication management and formulary restrictions. For veterans managing chronic conditions, and the vast majority of service-connected disabilities are chronic, medication access is paramount. The VA operates on a strict national formulary, a list of approved drugs. While this system helps control costs and ensures standardization, it often becomes a serious barrier to personalized, effective treatment. forcing veterans into a constant battle for the medications that actually work for them. The formulary is often outdated or overly restrictive. If a new, highly effective drug hits the market, perhaps a superior biologic for an autoimmune condition or a more tolerable antidepressant with fewer side effects, the VA is often slow, sometimes years slow, to add it to the approved list. This means veterans are frequently stuck on older, less effective, or side effect-laden medications simply because they are the preferred option for cost purposes. When a veteran's quality of life hinges on finding the right combination of pharmaceuticals, being denied access to the latest and best treatments feels like a betrayal. They are being forced to accept second-tier care because of budget constraints, not clinical necessity. To access a non-formulary drug, the veteran and their VA provider must engage in the non-formulary request process. This is yet another bureaucratic hurdle requiring justification, documentation of failures with existing formulary options, and approval from a centralized pharmacy board. This process is time-consuming, stressful, and often results in a denial, regardless of the compelling medical evidence presented. A veteran might have overwhelming proof that drug X works perfectly for their specific genetic makeup, while the formulary-approved drug Y causes debilitating nausea. Yet the VA insists on adherence to drug Y until the veteran literally proves failure through months of suffering. This cycle of forced failure is medically unethical and psychologically damaging. It forces veterans to endure unnecessary pain and side effects just to satisfy an administrative requirement. Furthermore, the VA's approach to pain management, particularly since the nationwide focus on the opioid crisis, has created its own set of problems. While necessary controls are crucial, the pendulum has swung so far that many veterans with legitimate, severe chronic pain are now being dramatically undermedicated or forced through rapid, aggressive tapers that leave them functional impaired and in agony. They are often treated with suspicion, viewed as potential abusers rather than patients in distress. This hostile environment, combined with the restriction on specialized pain medications, leads veterans to seek relief elsewhere. They realize that in the private sector, a pain specialist has far greater latitude to prescribe complex multidisciplinary treatment plans, including non-opioid alternatives and advanced interventional procedures, without the constant fear of administrative audit or punitive measures. The VA's rigid medication protocols, driven more by centralized control than individualized patient needs, actively push veterans toward private pharmacies and private doctors who can offer the flexibility required for complex chronic care. The fight for the right pill becomes so exhausting that veterans decide it's easier to just pay for it themselves or use a separate insurance plan entirely, rather than continue the endless war with the VA formulary. The fourth major systemic issue is perhaps the most insidious because it directly impacts the human connection in healthcare: the crisis of retention and staff burnout. Healthcare is fundamentally relational. A patient needs to trust their provider, and the provider needs to know the patient's history, nuances, and personality. In the VA, high turnover among medical staff, doctors, nurses, and especially primary care providers, PCPs, has shattered this essential continuity of care, leading to inconsistent, disjointed, and often dangerous treatment. Why the high turnover? VA staff often cite overwhelming patient loads, outdated technology, intense bureaucratic scrutiny, and salaries that, while competitive in some regions, often fall short of private sector benchmarks in major metropolitan areas. The emotional toll of caring for a population with complex, often severe, trauma-related conditions also contributes significantly to burnout. When staff feel unsupported, overworked, and constantly fighting the same internal administrative battles as their patients, they leave. And when they leave, the veteran suffers. Imagine a veteran managing complex conditions like diabetes, PTSD, and severe joint pain. They spend a year building trust with a PCP who finally understands the delicate balance of their medications, their triggers, and their unique history. Then one day the veteran receives a letter. Dr. Smith has left the VA. You have been reassigned to Dr. Jones. Dr. Jones is new. Dr. Jones has 2,000 other veterans on her panel. Dr. Jones has to start from square one, reviewing thousands of pages of records, many of which are poorly organized or incomplete. The veteran is forced to recount their entire medical and traumatic history yet again. This isn't just frustrating, it's clinically risky. Critical details get lost in the transition. Medication interactions that the previous doctor managed carefully might be missed by the new, overwhelmed provider. The emotional labor required to reestablish trust and re-educate a new doctor is immense, especially for veterans dealing with service-related trauma who struggle with vulnerability and authority figures. This rapid cycling of providers ensures that veterans rarely receive truly individualized, long-term care planning. They receive transactional care, address the immediate symptom, manage the immediate medication refill, and move on to the next patient. There is no time for proactive health management, preventative care, or deep dives into complex diagnostic puzzles. Veterans recognize this pattern. They see the exhaustion in their provider's eyes, and they understand that their provider is fighting the system just as much as they are. But ultimately, the veteran is the one who bears the cost of this instability. When a veteran realizes they are just a number on a spreadsheet, constantly shuffled between temporary caregivers, they seek the stability and continuity offered by a private practice where they can build a decade-long relationship with a single, dedicated physician. The lack of provider familiarity and the constant churn of staff are silent but deadly drivers of veteran dissatisfaction and abandonment of the VA system. It undermines the very concept of a medical home. The fifth structural impediment that cripples care is the digital divide and record inaccessibility. In the 21st century, integrated, seamless electronic health records, EERs, are the backbone of modern medicine. They ensure that every doctor, every specialist, and every emergency room has immediate access to a patient's full history, test results, and treatment plan. The VA's struggle with EHR modernization is legendary, costly, and continues to pose a significant threat to veteran safety and continuity of care. The VA currently operates on a mix of legacy systems, primarily Vista, and is in the process of a massive, troubled, and highly controversial migration to a new platform based on the Cerner system. This transition has been plagued by massive cost overruns, technical glitches, and critically, system outages that directly impact patient care. While the goal is integration, the reality is fragmentation. Records often do not communicate seamlessly between different VA facilities, especially across regional lines. If a veteran receives care at a VA facility in California and then moves to Texas, accessing their complete, up-to-date chart can be an administrative nightmare. Time-sensitive test results might be delayed, or worse, missed entirely, because they are trapped in a system that doesn't talk to the new one. The problem is compounded when the veteran requires community care. The VA system often fails to communicate effectively with the private sector EHRs. When a veteran sees an authorized private specialist, the specialist may have difficulty accessing necessary VA records, imaging, labs, historical diagnoses. Conversely, when the veteran returns to the VA, the private doctor's notes and critical findings often fail to transfer back into the VA system in a timely, usable format. This forces the veteran to become the courier of their own medical history, hand-carrying CDs of scans or stacks of paper notes between facilities. This isn't just inefficient, it's dangerous. A private doctor might prescribe a medication that interacts poorly with a VA-prescribed drug, and the VA doctor might not know about the new prescription until the veteran suffers an adverse event, all because the digital bridge failed. The veteran's frustration is palpable. They look at the billions of dollars spent on modernizing the system and see no tangible improvement in their ability to receive integrated care. They see a system where crucial health data is siloed, inaccessible, or simply lost in the digital ether. This record chaos creates a profound lack of confidence. If the VA cannot reliably track a veteran's medical history, how can the veteran trust the quality of their diagnosis or treatment plan? When veterans realize that private hospitals and clinics have far more reliable, integrated digital systems that allow immediate, seamless data sharing, the choice becomes clear. They are seeking a healthcare experience where their history follows them, not one where they have to drag their records behind them like a heavy, outdated suitcase. The digital divide is a profound barrier to modern care, and it is a major factor in veterans choosing to exit the system for reliable, integrated private sector technology. Next, we confront a deeply painful and sensitive issue that hits the core of why the VA exists: mental health stigma and resource overload. While the VA is often lauded for its robust mental health services, for many veterans, the reality of seeking psychological care within the system is fraught with stigma, long waits, and a profound fear of negative repercussions on their disability claims or military record. This fear often outweighs the need for help, leading to untreated crises and ultimately driving veterans to seek confidential, private support. The primary issue is the perceived linkage between seeking mental health treatment and the disability claims process. Veterans fear that admitting to severe PTSD, anxiety, or depression, especially if those conditions worsen, will be used against them by the VA raters to argue that their service-connected disability is not as severe as claimed, or conversely, that their ongoing treatment records will be scrutinized and used to justify a reduction in their disability rating. This atmosphere of surveillance, whether real or imagined, is toxic to therapeutic trust. A veteran is supposed to be fully honest with their therapist, revealing their deepest vulnerabilities and struggles. But when that therapist is a VA employee and their notes become part of a record that can be reviewed by claims adjudicators, the veteran often self-censors. They hold back crucial information, minimizing their symptoms or avoiding discussion of sensitive topics simply to protect their financial stability. This makes therapy ineffective, shallow, and ultimately useless. Beyond the claims issue, the resources are often critically overloaded. While the VA has hired thousands of mental health professionals, the demand far outstrips the supply, particularly for specialized, evidence-based therapies like trauma-focused cognitive behavioral therapy, TFCBT, or eye movement desensitization and reprocessing, EMDR. Veterans face long waiting lists just to get an initial assessment, and then often face further delays for weekly, consistent therapy sessions. A veteran in crisis needs immediate, reliable access to a therapist, not a 6-week wait. When they are finally assigned a therapist, that therapist is often managing an overwhelming caseload, leading to rushed sessions, frequent cancellations, and the same lack of continuity seen in primary care. Furthermore, the VA's approach, while improving, sometimes struggles to move past a generalized, one-size-fits-all model. Veterans need therapists who understand the specific culture of the military, the unique stressors of deployment, and the complex moral injuries associated with combat. While many VA therapists are excellent, the sheer volume of patients means that veterans are sometimes paired with clinicians who lack specialized military trauma training, leading to a feeling that they are not truly understood. When a veteran feels minimized, misunderstood, or worst of all, judged for their trauma, they stop seeking help. They realize that private sector trauma specialists who operate outside the claims bureaucracy and can offer absolute confidentiality provide a safer, more effective environment for healing. The stigma and the fear of financial reprisal are powerful deterrents, forcing veterans to choose between their mental health privacy and the perceived necessity of staying within the VA system. This choice is often the final push they need to quit the VA entirely for sensitive, crucial care. Finally, we arrive at the point that often seals the decision for veterans to leave, because it involves the unexpected financial devastation that the system can inflict. The financial tipping point: unexpected billing. Veterans rely on the VA because they believe their service-connected care is covered and that their non-service-connected care will be affordable. They assume that navigating the VA system protects them from the crippling debt that plagues the private American healthcare system. This assumption is tragically wrong. The VA system is riddled with complex billing disputes, surprise fees, and ambiguous rules regarding service connection that result in unexpected, crippling medical debt. The most common trigger for surprise billing occurs when a veteran uses community care. Remember the bureaucratic quagmire? When the VA authorizes a referral to a private doctor, that authorization is supposed to guarantee payment. However, the process is so messy that authorizations often expire, are incorrectly processed, or are retroactively denied. A veteran goes to a private facility, receives treatment, and months later receives a massive bill because the VA refused to pay the private provider, claiming the authorization was invalid, expired, or that the treatment rendered was outside the scope of the original referral. The veteran is caught in the middle, facing collections, credit damage, and the immense stress of fighting a billing department that is entirely separate from the VA. They are told, "This is between you and the provider," even though the VA was the entity that initiated the care. Another major flashpoint is the definition of service-connected care. If a veteran has a service-connected knee injury and they seek treatment for chronic pain in that knee, it should be fully covered. But what if the doctor determines the pain is actually radiating from a hip issue that is not service-connected? The VA might cover the visit but refuse to pay for the hip imaging or subsequent treatment, resulting in a sudden high-cost bill. Veterans often don't receive clear, upfront communication about what is covered and what isn't, especially when conditions overlap. They rely on the VA for guidance, only to discover after the fact that they owe thousands of dollars for procedures they thought were part of their covered care plan. This ambiguity is a financial trap. Furthermore, there are unexpected costs associated with certain VA services, particularly non-service-connected prescriptions or specialized procedures that require co-pays. While these fees are often low, they add up quickly, especially for veterans on fixed incomes. More critically, if a veteran has a dispute over a bill, say they were charged a co-pay they believe they shouldn't have been, the process for resolution is agonizingly slow and opaque. They are fighting a massive government agency, and often the easiest path is simply to pay the incorrect bill to avoid collection actions. The fear of surprise bills, the stress of constant billing disputes, and the realization that the VA system is not the financial shield they believed it to be, forces many veterans to seek the predictability of standard private insurance, where at least the rules of engagement are clearer, even if the copays are higher. They quit the VA because the administrative chaos carries a devastating hidden price tag. So, where does this leave us? The exodus from VA healthcare isn't driven by a single failure. It's the cumulative weight of systemic dysfunctions that erode trust and compromise health outcomes. Veterans are quitting because the illusion of comprehensive care forces them into unacceptable waiting times for specialists. They are quitting because the bureaucratic quagmire of community care turns seeking outside help into a full-time job. They are quitting because formulary restrictions force them to accept subpar medications. They are quitting because the crisis of staff burnout means they never see the same doctor twice, destroying continuity. They are quitting because the digital divide means their medical records are perpetually lost. They are quitting because mental health stigma forces them to choose between treatment and their disability rating. And they are quitting because the financial tipping point one knee of surprise billing threatens to bankrupt them. The VA system, built on the noblest of intentions, is currently struggling under the weight of its own inertia. Veterans are making a rational choice. Their health and their peace of mind are simply too valuable to risk on a system that seems determined to fail them through bureaucracy and delay. If we truly want to honor the commitment made to those who served, the VA must move beyond incremental fixes and address these core structural failures. Until then, the exodus will continue, one frustrated, untreated veteran after another, seeking the dignity and quality of care they earned but cannot find within the system designed for them. The message is clear: the system must change, or it will be abandoned.